Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Consensus or Controversy. This is today we're going to talk about the management of myelofibrosis. We have a great faculty today, Professor Claire Harrison from the Guy's and St. Thomas NHS Foundation Trust in London, United Kingdom, and Dr. Raajit Rampal from the Memorial Sloan Kettering Cancer Center in New York City. We also recruited 4 other investigators, Drs. Bose, Kuykendall, Mascarenhas, and Jacob, to take a survey that you're going to find of great interest. This was a big day for myelofibrosis at ASCO this morning. Today we're here to talk about myelofibrosis, and as is all of our programs nowadays, we will be talking about the use of unapproved agents and regimens. So check out the package inserts of the various products that we talk about today. We're just finishing up. This is the 14th program we've done since Friday. This is a wild ASCO. We never tried to do this before. It went great. We had 12 different investigators moderating meetings. This is like what you call see one, do one, teach one. They did a great job. And thanks to our staff, like amazing, Catherine, Kirsten, Kevin, Sylvia, Christina, and many more people. I can't believe that we actually pulled this off, so congratulations. But here we are now at the end, and we never imagined when we planned this that this is going to be as exciting as it is, because this morning was a myelofibrosis oral session, and as you probably know, there's a big phase 3 trial presented with selinexor. We're going to talk about that in a little bit. But first, I want to just take a breath. Here's where we're heading. We're going to start out. We'll be talking, Claire will be giving a brief review of some of the key data sets and the management of myelofibrosis in patients without cytopenias. And then Raajit will talk about patients with cytopenias. And along the way, we're going to show you the results of a survey we did of the faculty and the other 4 investigators that, believe me, was very interesting and helpful. So before you get started, though, I was telling the faculty we really based our programs and research to practice on rounds. We got into audio. So, even though we're showing a bunch of slides here today, we're also aware that a lot of people end up listening to this, driving their car, working out, etc. So we're going to start out. And, I always loved graphics that are in trials. And Claire did 2 papers that had these really great graphics. We actually tried to get permission to use them, but we couldn't get that by the time we started here. But check out these papers if you want to get into some of the pathophysiology we're about to talk about. But what I really wanted to do is take another shot at my long history of trying to understand what this disease is molecularly, Claire. And I want we'll start out with you. Man, why don't you just talk a little bit about, we know there are 3 types of mutations, driver mutations that you see. But can you talk a little bit more about your vision of what's going on inside the cells? How do these driver mutations, what pathways do they affect? And how do agents like JAK inhibitors help improve patients? We'll start with you, Claire.
Sure. Well, hi, everyone. I think it's interesting you raise this question because we know about our 3 main driver mutations, predominantly those affecting JAK2, especially V617F. And our belief that causes a constitutional activation and drives the JAK-STAT pathway. We also understand that the second commonest range of mutations are the calreticulin mutations. And as we may get a chance to discuss later, these actually turn out to be a kind of perfect magic bullet mutations, but they're also signaling down the JAK-STAT pathway, predominantly, we believe, from the thrombopoietin receptor MPL. And then lastly, in around 5 to 10% of patients, there are a few different mutations affecting MPL, causing dimerization and again signaling down JAK-STAT. So, predominantly this is about JAK-STAT signaling, but it's not that simple because there are multiple other pathways that are interdependent, and JAK-STAT also affects sort of nuclear signaling, it affects phosphorylation of histones, etc. And it has wider effects outside of the cell. So we see effects on inflammation and if you look in the marrow of a patient with myelofibrosis, not only do you see fibrosis, but you also see alterations in innervation and vascularization. So for the most part, JAK-STAT, but that's not the whole story. And once we start inhibiting JAK-STAT, we also are driving lots of bypass mechanisms and potentially selecting for other mutant pathways. For example, the RAS pathway has become of interest in this field.
So, Raajit, anything you want to add to that? And can you kind of separate out, we think driver mutations, I mentioned about lung cancer, et cetera. You think about, if you can get a targeted therapy against the mutation, you can decrease the number of alleles, you slow the disease process down. But when I think about myelofibrosis, I also think about what Claire was just talking about, just the cytokine activation that you see and the debilitating effect it has on patients. Anything you want to say about separating those out as we look at trials, what we need to look at to try to understand, at a cellular level, how do we benefit patients?
Yeah, I think one way to add to this is that this is not a cell-autonomous disease, right? So let's draw a parallel to AML. When we think about AML, simply we think about blasts. Did we get the blasts, into an MRD range or at least under 5%? That is success. Here it's a different thing because, we, as Claire has pointed out, we have these JAK-STAT mutant cells that often have other genomic abnormalities. But what happens with this disease is they influence the environment. They influence the cells in the bone marrow. They influence the cells in the spleen. Part of this is through cytokines. Part of it is through other mechanisms. And so as we think about what is achievable with current therapies and success, can we inhibit JAK-STAT? Yeah, we have drugs that can do that. We have new drugs coming that can maybe do it more potently. But the effects that happen in the rest of the environment, in the spleen and the bone marrow, these are not things that resolve quickly, right? We know this from transplant. It takes a year for the bone marrow to recover really from a transplant. So, this is a disease that is both chronic, but not stable, meaning that there is slow progression of disease. Part of that is because of damage that is ongoing from these cells to, the environment in which they live. And that to me is one of the things that distinguishes it from something like AML.
So that's very helpful. And now we're going to get into some more clinical research data, but also want to keep this theme in mind as we talk about newer therapies, particularly targeted therapies. Even, we'll talk maybe later about things like CAR T or bispecifics, and how these different targets might be susceptible to that type of strategy. But first, Claire, we asked you to review some of the data that we have. But first, I'm going to go through before you get into your data, some of the findings that we found from the survey. So I'm just going to go back and forth between the two of you. Audience, you can check out what all the other people said and go back and look at this later too as well, because this is posted in the chat room. So question number one, Claire, what's your stress? You have a patient who has low risk MF. What about what's your threshold in terms of symptom burden, including splenomegaly, for activating treatment?
Well, I think you have to listen to the patient story. How much are the symptoms affecting the patient? So for me, just example, spleen. If it's just got 1 centimetre bigger and the patient's not really symptomatic, not too worried. However, there are a range of symptoms, as our listeners probably know, particularly fatigue, pruritus, night sweats, etc., which can be problematic. And of those, only night sweats, of course, really would push a patient's risk up. I also reflected that, for me, actually, I think progressive leukocytosis or thrombocytosis are something that would make me think about using a treatment, because I have to remember these patients can also get thrombosis.
I think you'll notice for a lot of these, you get very similar answers for these questions that have been out there for a while, but always good to reinforce for people like me who need to update it. So Raajit, in what situations would you start treatment of a patient with MF who's asymptomatic? Most people, including you, talk about splenomegaly. Can you give me an example?
Yeah, to me, there is both such a thing as treating too early and such a thing as treating too late. And if we were to pick what is the bigger sin in practice, it's treating too late. Massive splenomegaly to me is a key example of this, right? And it's often that patients have had splenomegaly for a number of years. They become used to it. But the spleen progresses in size, and now people start to get, thrombocytopenia from the massive splenomegaly, which makes it harder to deliver therapies. There is a spiral that occurs if you wait too long. And massive splenomegaly is a very subjective term, but I think the point for the audience is that there is such a thing as waiting too late to treat an enlarged spleen.
So, Claire, when I was watching the session this morning, I had a little bit of a comfort flashback to 2011, where you and Dr. Versavec presented the Comfort 1 and 2 trials. And that, when you presented that, I think everybody, including me, got chills. I mean, it was an incredible moment, I think, in this disease. I had a little bit of a flavor of that this morning, but anyhow, we know about a third of our audience has been in oncology less than 10 years, so they weren't around when Comfort came out at that ASCO meeting. Here, just to remind people that most people respond to ruxolitinib. Anything you want to say about it? You say almost everybody.
I'd say it's very rare for patients not to get a response, provided you use a good enough dose. And that's a complexity of using ruxolitinib, is being sure that you give a big enough dose. And that's where cytopenia, as we'll discuss, becomes a problem. The trouble is that reduction isn't always sustained, and it may not be deep enough. We can get into a discussion about that, I guess.
I remember the stories that I was hearing around that time of these patients who were terribly, terribly sick, and then it was amazing to be a clinician and see this being introduced. But as you mentioned, dose has always been an issue here. We asked these in this survey what the usual starting dose is. Most people say 20, although a couple of people say 15. Then we say frail 80-year-old, and Raajit, you go down to 5 milligrams. Anything you want to say about, there's a little bit of variability here in what people do?
Yeah, I think to Claire's point, it really is a question of where are you going to end up, not where you start. And in my experience, particularly for older patients, I like to start low and then up titrate the dose. But the key to that strategy is not waiting too long, meaning that one should not increase the dose of Rux by 5 twice daily every 3 months. You should do it every couple of weeks to get to your target. So it's more about how you get to the target.
Yeah, that's a great point. We see this a lot in oncology all across the board. People a lot of times want to start out, particularly in older, frail patients, at a little bit of a lower dose. And, our way of doing consensus conferences, when we ask everybody a question, they all get the same answer. So everybody says 25 milligrams is as high as 25 BID is as high as they're going to go. But you'll see there's not necessarily consensus on everything here, as always in oncology. But Claire, let's take a moment and take a look at some of the data that's kind of behind these.
Sure. Well, we're going to have to go quick because there's so much. Right. So as we've heard from the cases that we've discussed, and all the listeners will know that the burden for patients is driven by splenomegaly, fibrosis, cytopenias. But I would say a burden for patients is also the knowledge that for most patients, their disease is incurable and their survival trajectory will be affected. What we also understand is whilst JAK inhibitors are good, they are not perfect. 97%, I think, have a reduction in spleen, but these reductions are not always durable and they may not hit the target. They don't resolve the underlying pathobiology, and the responses are not always durable. So there are significant unmet needs. We're really alleviating splenomegaly and symptoms. There's only modest survival benefit, but there is. And most patients can't undergo a stem cell transplant. And for many, I think that's a really scary decision. So we do need novel agents. So we're going to take a look at what novel agents there are and the limitations of JAK inhibitor monotherapy. How can we overcome that? Well, I think one way of overcoming it is to, as Raajit nicely said, treat early, but also treat well with a good dose. And then let's take a look at some of the novel strategies that we might use. First, some data just to remind the audience about, this is some data from a pooled analysis of those very old studies, Comfort 1 and Comfort 2, showing that patients who were treated within 12 months of diagnosis were more likely to get spleen response and more likely to get symptom response And if you look at the graphic on the right, they're more likely to get better survival, more on spleen and survival later. Many patients, as we've heard, have inadequate response, but we don't define that very well. We had a lot of definition about when to start treatment, but we could have had even more discussion about when to say it's not working well enough. So there's a bunch of different targets that we're looking at in the field. And these are affecting lots of different pathways: epigenetics, apoptosis, telomerase, other cellular signaling pathways. And there's a bunch of combination approaches that we're looking at, and colleagues will be aware of data with pelabresib, imetelstat, luspatercept, navtemadlin, navitoclax in the past, and then more recently selinexor. So quickly to walk colleagues through, our second biggest ever study in myelofibrosis is a study that both Raajit and myself have been extensively involved in, the MANIFEST study, adding pelabresib, a BET inhibitor, to ruxolitinib in frontline MF patients. This study demonstrated significant doubling of spleen response at week 24 that was sustained at week 96. So these patients are still randomized, and we're looking for the 144 week data to come soon. So do watch out for that. Symptom improvement over and above ruxolitinib not met, a common theme. But that study, do watch out for the longer term results. Next, I wanted to point out imetelstat. There was a study looking at 2 different doses of imetelstat published by John and others. Imetelstat is a telomerase inhibitor. The higher dose of imetelstat delivered spleen and symptom responses and was linked both to a survival benefit and fibrosis reduction. And we should see an interim readout from a study looking at imetelstat as a monotherapy later this year or next year. And we're currently recruiting a study of imetelstat in combination with ruxolitinib. The drug of the moment is selinexor, which you may be familiar with in the context of myeloma, but it does have a rationale for its use in myelofibrosis. It leads to JAK-STAT pathway inhibition, p53-driven cell death, cell cycle arrest, and also affects NF-kappa B pathways like pelabresib. And what was presented today was the result of the Sentry study, and it's just been published as well in a synchronous publication in JCO. So taking a quick look at this study, for those of you who may have missed it, double-blind, 2-to-1 randomization, including intermediate 1 and above risk MF patients with a spleen and a symptom burden, primary endpoint spleen and symptoms, doubling of spleen response, almost, so 49.8% versus 28% with just placebo and Rux. So this is something we're used to with combinations, but take a look at the graphic on this slide. The changes with selinexor were present from 12 weeks and they deepen over time, whereas there's the impression of a plateau with ruxolitinib. So deep, durable and progressive spleen responses that are statistically significant. There was a miss in terms of superiority of symptoms, and maybe we'll get into tolerability discussion about selinexor, but the symptom reduction, the symptom control was as good probably. But hot off the press, meaningful overall survival with a hazard ratio touching 1, but the sense that there was a survival benefit by 11 months for the combination. SVR at week 24, predicting survival. So again, in line with the COMFORT studies. But I can hear you asking, selinexor, use that drug for myeloma. We're using it at a different dose in myelofibrosis, so a lower dose and in combination with ruxolitinib. Generally, a fair balance of adverse events, more fatigue and more nausea with the selinexor combination. But leukemias were balanced between the 2 arms. With pelabresib, there was an initial imbalance in leukemias, which has now kind of rectified itself. Another agent in a clinical trial is navtemadlin, which is an MDM2 inhibitor, so looking at apoptosis. The Boreas study was presented by John recently, and we have the ongoing POESIS study. So this drug, as a monotherapy, did lead to spleen responses in the second line, and the POESIS study is of interest because it's looking at suboptimal responders with ruxolitinib, which could be a new target, if you like, for the future, or a new way of thinking about therapy, and might even be a way that we might use selinexor potentially in some patients. So there are lots of emerging therapies and combinations, very exciting data with selinexor, but I think other exciting data to come in the MF setting. Earlier use of JAK inhibitors, more rational use, but also combinations. And then also you'll see mutation-specific therapies and updates on them, such as the CALR therapies and others. So thanks for your attention. A bit of a whistle-stop tour, but looking forward to discussing. Oh, here you go. This is a great graphic from blood. I love this. Damashek's beach. And then the surface being the mutation-targeted therapies. Thanks, teams, for reminding me that I borrowed this graphic from blood.
Yeah, I love this. I always like pictures like that. Anything else you want to say in terms? One of the things that came up this morning was the issue of endpoints in upfront trials. And, do you really need something that's going to beat ruxolitinib? And of course, the issue of survival came out this morning. Raajit, anything you want to say about that? This is Claire's slide, but anything you want to say about where you see this heading? In other diseases, people are looking for, endpoints that are predictive of survival, MRD assays, which I don't think you guys really have. But what are your thoughts about that, Raajit?
Well, I mean, look, from a high level, this is what we want for patients, is for them to live longer without sequelae of disease, right? And that is OS and PFS. Now, are those things really going to be achievable in a 6-month study? I don't think that's likely. We have to follow the patients, and that's one of the lessons I think from both selinexor but also from pelabresib is we have to follow the patients and see what these drugs are actually doing long term to help patients. I think that because we understand a fair amount of the molecular pathophysiology of the disease, not entirely, there is the opportunity to think about surrogates, molecular surrogates or biomarkers of response. We don't really have good ones at the moment, but I think that is also, an area that is likely to be fruitful as we think about surrogates for OS and PFS.
So we'll get into selinexor in a minute. I think you're going to find this survey very interesting from that point of view. But first, again, just getting back to some basic management questions in terms of where we are in 2026. First question here is, Claire, what's your threshold to move from Rux to fedratinib in a patient?
Well, briefly put, I said lack of response or progression. I think the issue with fedratinib is actually it's a really good drug for treating the spleen, but it does cause more anemia. So for me, there are some complexities of using it in the UK, which I won't go into. But for me, it's a spleen drug, and it's useful for patients who have platelets between 50 and 100. So there's some nice data showing it's helpful there. It also, interestingly, happens to be a bromodomain inhibitor or have some activity there.
So let me just go through here. What about, Raajit, the patient where you decrease the dose, you want to stop therapy? We know that you can't stop ruxolitinib. You can talk a little bit about what happens if you do stop ruxolitinib immediately and how you taper it off. You say over a couple weeks, 10 milligrams a week. What happens if you don't do that? And what's your experience with this type of tapering, Raajit?
Yeah, no, important, really, really important practical question, for those in practice, right? So it really depends on where you're starting. Well, the thing we have to be careful of that is what we've known is that if you do abruptly stop JAK inhibitors, patients can develop a SIRS-like syndrome, which has been reported to be fatal in some instances. So we always want to taper it if we're going to switch. And I think, one of the teaching points always for people who prescribe these drugs is that if there's a situation where you have to stop it abruptly, bridging with prednisone can be an effective measure to, reduce the risk of that happening. Now, if you're switching from one JAK inhibitor to another, you're switching from Rux to another inhibitor, if someone is on a dose of Rux of 5 twice daily, you don't really need to taper. You can just go directly from that dose to, your next line therapy. It's a different thing if somebody is at, for example, 25 twice daily, right? That requires some careful tapering. And, this is sort of like, I'm sure many people in practice are still familiar with Coumadin, right? It's sort of like, adjusting Coumadin. There isn't a strict algorithm. It's a little bit of trial and error. And so typically what we do is try to reduce the dose by 5 milligrams every 2 to 3 days, until we get to that 5 twice daily dose. The other thing I will say is that when you are switching from one JAK inhibitor to another, we often do overlap drugs by 1 or 2 days. And that's just, because of the kinetics of starting the new drug and, waiting until you have the right steady state of the drug concentration so that the patient isn't feeling too many effects of withdrawal. So doing, a low dose of Rux for 2 to 3 days while you're adding another JAK inhibitor is something we do in practice all the time.
What's your vision, Raajit, of the pathophysiology of the withdrawal syndrome? Is it basically a cytokine issue?
Yeah, I mean, I think the prevailing thought is this is essentially a cytokine storm, right? That you have all of a sudden unregulated production of cytokines that were previously tampered down.
So, research to practice, we have a kind of simple way of trying to figure things out is we just ask people what they do. And we present scenarios, and if everybody, like I said, if everybody does the same thing, we call it a consensus. We see 4 different answers. We know it's not a consensus. Before we get into the selinexor thing, I'll just tell you a quick story, which is 2 years ago. You may remember that ODAC met about belantamab mafodotin in myeloma, the ADC, and they actually voted 5-3 and 7-1 against approval because they were concerned about ophthalmic toxicity. And right around that time, we did a survey of investigators, and we said, if belantamab was available, would you use it? And they all said yes. And we said, well, how many people do you have that you'd actually start on it right now? And most of them had 4 or 5 people. And then by October, the FDA actually approved it, and it's now being used. So I don't know whether the FDA is going to look at this, but I think it's pretty interesting. It actually kind of reflects back on what happened this morning because Dr. Kuykendall, who we didn't know at the time, actually did the discussion of the paper that Dr. Mascarenhas had just presented, and we have both of them here on this survey. And I can kind of relate because I know you were both in clinic and didn't see this, although I'm sure you know exactly what happened there. But Dr. Kuykendall brought up the fact that there had been a couple of prior, as you already pointed out, Claire, trials of doublets that showed spleen response but not symptoms. It had not been approved. And he seemed kind of lukewarm about using it in his presentation. Although when the panel discussed it, the people brought up the issue of the patient who had big spleen, very symptomatic, hyperproliferative, et cetera, where they would want to use it. But again, we just asked people just to get kind of a flavor of, A, if it were available, would you use it? And incidentally, this another question that brought up this morning was, one thing that's different about selinexor than these other doublets is that selinexor is already approved and on the market. So theoretically, if the NCCN blesses it, it might actually be able to be used, whereas the non-approved agents cannot be used. So that was brought up as a possibility. But Claire, what we see here is that there are a bunch of people, including both of you, who say they would like to use it. Can you talk about what your thoughts are about that?
Well, I think we've seen very clear evidence that the drug does deepen spleen response and it may well affect biological pathways. Didn't really have time to say, but there is some data that also reduces the mutational burden for patients, as in the percentage of mutant allele, which I personally think is a strong front runner for disease modification marker. I fundamentally believe that for many patients with myelofibrosis, we don't have a good drug when a JAK inhibitor fails. And most of my patients are already on a JAK inhibitor. We might cycle them through different JAK inhibitors to try to improve anemia, but fundamentally, once they've failed on the spleen, we're in trouble. So I would like to be able to use this drug in that setting. I would also like to use it in the frontline setting for some of my patients. I don't think this is a drug where a difficult, unknown side effect is going to come out of the woodwork. So I would like to have the option to use it, yeah.
Raajit, what are your thoughts about this? And can you maybe describe a clinical scenario or patient you've seen where you would actually use this doublet up front?
Yeah, absolutely. Right. I absolutely agree with Claire. Like having a tool like this would be a good thing, particularly with the data that we've seen. I think that, as we do in oncology, right, all across oncology, we want to mix mechanisms of therapies, right, because we do think that there is additive effect biologically. So that makes sense rather than just cycling from one JAK inhibitor to the other. Now, where would one use this up front? To me, the scenario that I think of is the patient with a big spleen who is a transplant candidate, because we know for numerous studies that the size of the spleen going into the transplant absolutely affects engraftment, right? So if you could optimize the spleen by using a combination, then why not? Why wouldn't you do that and optimize the patient's condition before you take them to transplant? To me, that would be a very clear example of where I would use combination up front.
So I'm sure we'll be hearing a lot about this in the next few months, but also I'm curious about the issue of tolerability, Claire. We have a long history of talking about selinexor and CME programs in myeloma. Initially, when it came out, I think it was at a higher dose than is used here. There was a lot of people complaining about it. I used to go to Dr. Joe McHale. He was always my expert to explain how you get your nursing staff and everybody ready to give selinexor. But what I heard today, and both in the data as well as the discussion afterwards, I know they use dual antiemetics. It sounded like, it's a lot more tolerable than what we were hearing in the earlier on with myeloma. What's your experience, Claire?
Well, having treated patients, I still think it's probably pretty clear which patients are likely to be getting selinexor. However, I haven't stopped a patient because of nausea, and generally the dual antiemetics are helpful. And some patients are able to stop taking them or reduce intensity. I think the $64 million question might be, are patients willing to continue this drug year after year? Because right now we have data out to 11 months or so, but we know that if you stop a drug like this, likely the benefit's going to disappear for patients, right? So are they going to be able to continue to tolerate it? And is the fatigue and the nausea going to be a problem? Of course, we don't have a pill for fatigue. That's a big problem.
And that is a problem throughout oncology. Anything you want to add to that, Raajit? What's your experience been? I hear some of the comments from the faculty. Again, most people are using at least one antiemetic. You say an antidiarrheal, et cetera. What's your experience, and what do you think about this doublet, Raajit?
Yeah, I mean, this is, something where prophylaxis is really important, with as we know from anything in oncology, right? Drugs that cause GI side effects, you have to get ahead of them and not get behind them, because then you get into trouble. And so, do patients, does it become more tolerable for patients, when one is aggressive about giving antiemetics? Yes, you do run into the other problem, of course, of people becoming constipated from all of these drugs. So it does require some careful management. But, I think in many cases, the benefit outweighs the side effects, but the side effects are real.
So before we get into more data, just one more question back to you, Claire. I'm curious what kind of, let's say, complementary strategies that you find helps people with an MF, anything from diet, exercise, mental visualization, massage, any complementary strategies you find helpful?
Well, I think all of those things are helpful. I think also being able to talk to other patients is helpful, because these are rare diseases. People know about leukemia, people know about lung cancer, they know about pancreatic cancer, but you could have one of these diseases and look pretty healthy, actually, but still be feeling terrible. We have a fatigue clinic that our oncology, physios, OTs, and psychologists run, which is helpful for patients. But they say that fatigue with MF is different to fatigue with other oncological conditions. So I think it's a combination of, and something probably personalized to the patient.
Yeah, fatigue is so fascinating. You have these cytokines out there too. I'm sure those affect things. All right, Raajit,
Sure.
let's talk about really probably the biggest question that I hear from general medical oncologists, management of patients with anemia and thrombocytopenia.
Right, absolutely. So, getting into it, let's just put this in the context of a case. Let's say we have a 76-year-old with fatigue and weight loss and a spleen that's fairly large, 12 centimeters. But this patient has a white count that's a little bit subnormal, but hemoglobin 7.5 and the platelets are 44. This is, I would say, 20% of our myelofibrosis patients are like this, right? And these are the patients that are the most challenging to try to find a solution for because of the cytopenia. So how do we think about this? If we think about incidents of anemia and thrombocytopenia, certainly these are not rare things, but profound thrombocytopenia is certainly not a common thing at the time of presentation for most MF patients. It does increase in prevalence as time goes on. And the same thing is true of anemia. Anemia is, one of the diagnostic criteria, and you can see it in a high proportion of patients. But anemia, to me, is more of a clinical diagnosis rather than a numerical diagnosis, meaning that is it really impacting the patient? And the answer is that as time goes on, people do tend to become dependent on transfusions in many cases, meaning that it is impactful clinically. It's important to think about that both cytopenias are things that drive people's risk of death and progression. Anemia is part of all of our scoring tools for myelofibrosis, like the DIPSS. But in other tools like the DIPSS plus, thrombocytopenia is also a factor, right? So these are factors that drive our prognostic scores for patients. And that's even true of patients who are on therapy. If we think about what's called the RR6 model, that is a very useful thing. One of the things we know that for people on ruxolitinib is that if they are red cell transfusion dependent and they stay that way, that predicts for worse overall outcomes. So all of this is saying to us, this is not just sort of a management problem of numbers. This is a problem of patients who do worse. What do we do to deal with it? Well, we have JAK inhibitors, and I'll come back to that in a second, but we have old drugs that can sometimes be useful for anemia and thrombocytopenia. Things like IMiDs, like danazol, like steroids, like ESAs. These things can be helpful, particularly for thrombocytopenia where there are really few solutions and you don't really want to be using thrombopoietin mimetic drugs in myelofibrosis patients. Things like thalidomide and danazol can actually increase the platelet counts in 30 to 40% of patients. As it pertains to anemia, this is where I think we have a lot more options. We have old drugs like ESAs, but now we have JAK inhibitors that do have some anti-anemia effect. And we have another classes of drugs coming along as well that also work on anemia. So this is where I think the most progress in cytopenias has been made in the last few years. Now, in terms of selection of JAK inhibitors and thinking about cytopenias, pacritinib is a drug that really can be used for patients with a platelet count of under 50,000. There is no restriction on the platelet count. So, these are patients where you can use a full dose of pacritinib to try to get dose intensity, without worrying about what the platelet count actually is while giving therapy. For anemia, both pacritinib and momelotinib have this activity against ACVR1, and we think that this may be why both of these drugs appear to have somewhat of an anemia benefit. This is a pathway that regulates hepcidin, and so the thought is if you inhibit it, there's less hepcidin and more iron available for erythropoiesis. In terms of efficacy in the setting of cytopenias, for pacritinib, there's been a number of phase 3 trials, and we don't need to get into the details of all of them. But pacritinib certainly is a drug that can help shrink the spleen, and regardless of the platelet count, and improve symptoms. And we do see GI side effects with this drug, but they can be mitigated with prophylaxis. And the expectation is that many patients, the majority of patients, will have some degree of spleen size response. But what is also interesting, right? Again, this is a drug that we think about in terms of cytopenias, in terms of thrombocytopenia, is that there is actually a transfusion independence conversion rate for red blood cells, and this is a post-hoc analysis. But patients who did get pacritinib, about 37% of them were able to go from red cell transfusion dependent to independent. One thing to keep in mind for the audience is that this is not a quick effect. Oftentimes this takes months, sometimes 4 to 6 months before you will see this effect. So this is not something we tend to see very early on. And in terms of blood counts over time from real world experience, there does tend to be a stability of counts. And that's really important because with all JAK inhibitors, we see some degree of anemia thrombocytopenia, but with real world experience, we see that patients' platelets actually tend to be relatively stable and in some cases may even go up a little bit, with exposure to pacritinib. And momelotinib, of course, is another JAK inhibitor that can be used with patients with lower platelets. It's approved for patients with platelets of 25,000 and higher, but also anemia. And anemia is really where I think it's made its mark. It works, it seems, as well as ruxolitinib does in terms of spleen, maybe not quite as well in terms of symptoms based on randomized data. But where the major difference is the proportion of patients who become anemic on ruxolitinib versus momelotinib is very different. And we see that a higher proportion of patients are able to not become transfusion dependent or anemic when they are started on momelotinib versus those who are started on ruxolitinib. So that's one of the major ways to think about this. Again, I would put this into the context of anemia is a clinical situation. It is not a number. And it really depends on whether or not you think the patient is going to need something to prevent anemia or whether or not they're going to be able to handle that anemia without help. And we also see that momelotinib can help with improvements in symptom burden as well. So beyond what we see with these JAK inhibitors, we have other agents like luspatercept as an example, right? This is a activin ligand trap, and this is a drug that can be used also to help with anemia. It's approved for MDS, not for myelofibrosis, but we use it for myelofibrosis treatment in practice, and this is because of NCCN designation. And there is data from phase 2. A phase 3 trial was run, just so the audience is aware, which didn't meet its endpoint. But I think we haven't really seen the totality of the data. That's been by press release. But one of the problems with all of the anemia trials that we do is that the decision to transfuse a patient is a clinical decision. There is no set parameter that says you must transfuse a patient at a certain number. And so trying to understand differences in transfusion burden has a degree of subjectivity built into it. So nonetheless, I think the takeaway here is that we have multiple agents that can certainly improve anemia.
Great. So, Claire, let's want to talk a little bit about the issue of the patient who presents with anemia. Before we get to these survey results, can you just talk a little bit about how you think through a patient who presents with anemia and a patient who develops anemia while on ruxolitinib?
Well, I think that's a really important difference in terms of scenario. So a patient that presents with anemia needs a proper anemia workup. It's not always just due to myelofibrosis. These patients can have variceal bleeding, they can have B12 deficiency, etc. So they need a proper workup. The anemia of this disease is multifactorial. It's not only just due to JAK2 mutation and marrow fibrosis. I've been caught out lots of times with patients having B12 deficiency that kind of crept up and I didn't spot it. But on ruxolitinib, for example, or on a JAK inhibitor, if you inhibit JAK-STAT, you inhibit erythropoietin signaling and you cause anemia. It's an on-target effect. But there's a difference between the anemia that we see when we initiate the drug. We come to expect this nadir at around 12 to 16 weeks, returning back towards normal, depending on dose, versus an anemia that occurs in a patient that's otherwise on a stable dose. So I expect an anemia at the beginning, anticipate it, and manage the patient appropriately. So if a patient won't tolerate the anemia, I'm going to use a lower dose or support them. But if a patient develops anemia on drug, I'm worried about something else happening, disease progression or an intercurrent event. So early versus late anemia on a JAK inhibitor, I think about it in a different way.
So let's take a look at our survey. And Raajit, we asked this scenario in a 65-year-old patient, hemoglobin of 7 at baseline, requiring transfusions. And then we have two different platelet counts, one without thrombocytopenia, the other with a platelet count of 44,000. You say momelotinib for the patient with okay platelet count and pacritinib. Can you talk a bit about those answers? It seems to reflect most people, although others like Claire, will ask her in a second, say momelotinib for both of those scenarios. Can you talk about why you put your answer there, Raajit?
Yeah, I kind of think about this as dose intensity, right? And I would favor the solution that allows you to maintain the dose intensity of the JAK inhibitor. Now, as I mentioned, momelotinib is labeled for patients with a platelet count of greater than 25,000. So in the scenario with a patient a patient with platelets of 44,000, could you use momelotinib? Absolutely, you could. What we do sometimes see in practice, though, is even with a drug like momelotinib, when you start it, you do see some degree of platelet count decrease. And it's not a predictable thing as to what that number will fall to. So with a drug like pacritinib, I don't have to dose adjust if the platelets were to fall to, for example, from 44,000 to 20,000. Whereas if I was treating the patient with momelotinib, I would have to dose adjust based on those platelets. So that's at least one rationale. But both of these drugs are absolutely reasonable for these scenarios that are presented.
Claire, any comments? You say you use momelotinib for both of these scenarios.
Partly that's because we don't have pacritinib in the UK, outside of North America. Actually, it's not available. But my experience is that I generally would expect to see a faster transfusion response with momelotinib. As Raajit mentioned, it tends to be a bit slower with pacritinib, and I'm very comfortable with using momelotinib in patients with thrombocytopenia.
So I love this next one. It alternates responses, little heterogeneity here. So Raajit, 65-year-old man, symptomatic high-risk MF with splenomegaly, starts ruxolitinib 15 milligrams BID, limited response, and 6 months later presents with drenching night sweats, fatigue, abdominal discomfort, increasing spleen size, platelet counts 110, hemoglobin 8.2. You say fedratinib, and we'll ask Claire why she says momelotinib. But what's your thinking there, Raajit?
I think as Claire had mentioned earlier, fedratinib is really quite a good drug for shrinking the spleen. But anemia is a problem. More than 60% of people develop anemia with fedratinib. So this is a scenario where if the spleen is increasing, and that's really the thing that's driving our concern for the patient or the patient's concern, using fedratinib with an adjunctive therapy to support the anemia, to me, would be a very reasonable thing to do.
Claire, anything you want to say about your thought about momelotinib in this situation?
If I was with a resident in clinic and they suggested fedratinib, I would say that's also reasonable. I think momelotinib, you're likely to be able to give a full dose intensity. Either drug is a reasonable choice in that setting. But I went for momelotinib mainly because of anemia and dose intensity.
So here's another scenario. Same patient starts out 15 BID, has a symptomatic improvement, but then 3 years later, before I think it was 6 months, has a scenario of drenching night sweats, fatigue, etc., increasing spleen size. But now the platelet count's 44,000, hemoglobin 11. Actually, I'll come back to you, Claire, because you say momelotinib again, and we'll see why Raajit says pacritinib. Or maybe you said it because you don't have pacritinib available. I don't know.
No. In fairness, we were told it doesn't really matter. That was a deep joy for me because our market access is very different. For me, I was interested in the concept of using full dose of momelotinib for this patient, but I would also be happy to use pacritinib there. You only said which one, so...
Right. Okay. Let's talk a little bit. We have the EHA meeting coming up, and of course, we haven't seen the data yet, but I am curious what we ought to be looking forward to. Claire, any thoughts? We're going to see some more data on luspatercept. We've already talked about it. Now we have the phase 3 independent study. Anything that you're going to be looking to see there?
Well, I just really want to understand the story behind the press release that there was a benefit for patients, but a miss on the endpoints. And I think there'll be some story around transfusion practice. And it's really important that colleagues see the data with luspatercept, because I think it's an important option for patients.
So, Raajit, also we're going to see some data on AJX101, type 2 JAK inhibitor in patients who've been, I like how they say this, who have been failed by a type 1 JAK inhibitor. Anything there you're looking to see?
Yeah, this is a novel JAK inhibitor mechanism. All of our JAK inhibitors are type 1 inhibitors, and so there's a long biological story as to why type 2 inhibitors might be able to overcome resistance that we see with type 1 inhibitors. So, this is a second-line study, and, it's a very much JAK targeted. So I think we will see some... we'll see data, about the spleen, about symptoms, but also, about potential side effects like anemia, which we would expect to see with more targeting of JAK2.
So, Claire, before we go into some of the other EHA papers, again, you ought to really look at that discussion audience today. It was great. They had, I think it was about 25 minutes long, a fantastic presentation by Dr. Kuykendall and a discussion after that. But one of the things they were talking about is new agents, new strategies, directions, anything that you're excited about. They brought up a bunch of things I never heard of, but what about some of the traditional targeted approaches we see outside of MF, bispecifics? Claire, they mentioned this morning CAR T, and it looks like there's more sort of action around calreticulin, and here's a paper coming up that you're going to be presenting at EHA. Anything you want to say about that, and also the different targets, and why is calreticulin a better target for an antibody than the other two, or JAK, for example?
Well, at the moment, calreticulin is the only one of our mutations that's amenable to immunotherapy with a mutation-specific target. The mutant protein complexes with the thrombopoietin receptor inside the cell with the mutation, and it's expressed on the surface. So it's kind of and the wild type protein is not expressed. This is the first in class agent. We've seen a couple of presentations now. This is the second time it's being presented at EHA, but this is longer term data. It's important that we were talking about this already with selinexor, right? We want to see the data as it evolves. And so what we see here is reductions in spleen symptoms. We see anemia response, and the reason for anemia response here, we think, is because of restoration of normal hematopoiesis. So we're seeing beautiful images of the marrow with reductions in mutant CALR staining megakaryocytes and emergence of normal megakaryocytes. So we're having to think again about endpoints. But of course, we can also, and there are 2 CAR Ts that are addressing this target, and there are also 2 bispecifics, and there's an ADC as well, although there is no data in the public domain. This is very, very well tolerated. It's just a 30-minute infusion. So the main pain for the patient is they have to come to the hospital to have the infusion. Remarkably well tolerated for patients, and really, really interesting data.
Saturday night, we were talking about CD3 bispecific in small cell lung cancer. So, who knows where it's going to pop up next. So,
well,
Raajit,
at ASH next year for CALR, I think you'll see the data.
Awesome. So, Raajit, Anita in the chat room has an 84-year-old woman with MF for 6 years, was treated with ruxolitinib and was then transferred to her. And because of anemia, she switched the patient to momelotinib, and they had to stop the momelotinib because of, quote, anxiety and insomnia. Was that from the momelotinib, or could it have been from something else? I don't remember hearing about that one.
No, not really. I mean, what we've seen a lot with momelotinib is vertigo, and we often have people take it at night for that reason. But insomnia per se, not something that I recall having people complain about too much.
And anxiety, Claire. Any other like quality of life issues you've seen with momelotinib? This is the first I ever heard of that. Maybe it's coincidental. There's a lot of reasons for people to have insomnia.
So headaches. Vertigo, some peripheral neuropathy, which is dose-related, say around 11% of patients. First dose effect, hypotension. But I would say that in my clinical practice, sometimes what we see is anemia benefit, but not so good on symptoms for patients. So we do see some patients saying, actually, although my hemoglobin's better, my symptoms aren't so good. So they often then are switching back to ruxolitinib.
Yeah, Anita says that she follows up saying when the patient stopped the drug, the symptoms got better. So maybe, who knows?
There's the acid
What about
test.
this? Although that can be deceiving too sometimes. So I guess there's going to be another paper from the Simplified trials, Raajit, looking at symptoms after transitioning from them, just like with this patient here, going from Rux to momelotinib. Anything that you're going to be looking to see there, or what have you seen in terms of what happens to patients quality life-wise?
I think it's exactly as Claire said, that oftentimes we don't get quite the same symptom burden relief. And, the Simplify 1 data shows us that, right? That it was not a non-inferiority of momelotinib to Rux. So we've known that from the clinical trials. I think the thing is that every patient's symptom profile and burden is different. And for some patients, momelotinib does an adequate job, but it doesn't do the same job of Rux in terms of symptoms.
So final question, or getting back to EHA, Claire. Century 2, this is really interesting. Selinexor monotherapy up front in JAK-naive patients. I don't know if you know what that's going to show. And also, I was going to ask you before if you want to take a shot at explaining, again, the biologic pathophysiology of how selinexor works specifically in MF. But any thoughts about this monotherapy? It's really interesting.
Well, I think it's really important to understand that a drug works as a monotherapy if we're going to be combining it, especially in treatment-naive patients. Selinexor does affect JAK-STAT signaling. It affects NF-kappa B. It affects apoptosis and also cell cycle. So that there's a strong biological rationale for this drug, and it could well work as a monotherapy. In this study, patients are getting it as a monotherapy, and if they still have residual splenal symptoms, they're then having an add-on JAK inhibitor. I think it's an interesting and important study.
So, Claire and Raajit, thank you so much for working with us today. Audience, thank you for attending. Be safe, stay well, and have a great night. Claire, thank you so much. Raajit, thanks so much.